aeroplanes, we have seen people, not patients, people plugging cotton pledgets in their ear, when I suppose the best way would have been to plug the cotton pledgets in the nose. What is the Abramson definition of cholesteatoma? Example of the potential positive findings in a case of left-sided ear disease having cholesteatoma. Foul smell is seen in chronic otitis media squamosal type and rarely seen in chronic otitis media mucosal type. One of the MBBS students had asked me this question, sir, if foul smell is caused by anaerobic organism growth in chronic otitis media squamosal type, then if the same organisms grow in chronic otitis media mucosal type, wouldn't there be foul smell in that discharge also? Not develop tunnel vision and not only think about ear and brain, it can be something else also. That's very well said, Dr. 33. A piece of brownish debris just present in the attic. How should you approach it? A very good definition was given by Abramson et al. It is excellent but very difficult to remember. So, Dr. Thoritri, could you please tell me the definition by Abramson et al. Of cholesteatoma? Hello viewers, in today's video I will try to recreate one of the most feared scenarios in the life of a postgraduate resident. That is how to tackle the dreaded, the nightmarish long case. And the most commonly asked topic in long case in MS ENT or DNB ENT postgraduate exams, the final university exams, is usually dealing with chronic otitis media squamosal variety. Some of the commonly asked questions were compiled by me and my co-postgraduate trainee. Both of us were in the same boat way back when, and most of the credit goes to my colleague. He had written it down, and somehow I managed to recover that list, and I felt it would be a good idea to go through the potential questions with a postgraduate trainee from the modern era. With that out of the way, let's welcome to the channel for the second time Dr. Dharitri Mukherjee. Are you ready for the long case simulation?
Yes, sir.
As you can see, I am standing outside the Royal College of Surgeons of England, and we are going to discuss a very important topic, that is chronic otitis media squamosal type, which has been a cause for nightmare for all PG residents in ENT. Dr. Dharitri Mukherjee has secured stellar marks in her university exams, so we can really count on her answers. And if they are wrong, then I'll be happy to point them out. So the first question, we will not go into the details of the history and how we should take it. If you want me to discuss that, do let me know in the comment section. We will start directly with a case who, let's assume, has left-sided disease. The disease is cholesteatoma, and let's look at the questions that commonly are asked by the examiners once you have presented the history during the long case. Usually the examiner starts the questioning either with one out of the two following questions. The question may be, what is your case? Or it may be, what is your diagnosis? Now they might sound very similar or very easy to answer, but they are not. So let's tackle them one by one. Let's start with, what is your case? What are you likely to say if you're asked, what is your case, Dr. Saritri?
So when the examiner asks what is your case, one should be starting with the summary. If midway the examiner just points out and says, no, I want your provisional diagnosis only, then you just talk about the provisional diagnosis. Otherwise, it's the entire summary that you should be saying.
If the examiner asks you, what is your diagnosis?
Then you just talk about the provisional diagnosis.
I would answer it in a slightly different way. If I was asked, what is your case? This is what we were taught when we were postgraduate trainees in the prehistoric era. The question, what is your case? We would always answer with right from the patient particulars. We would not disclose the name, obviously, because of confidentiality reasons. What is your case meant? We would talk about the entire thing. And if the examiner then interrupts us and says, just tell me the summary, we would mention the summary. And what is your diagnosis? We would start with the summary. And again, if the examiner interrupts, we would go directly to the provisional diagnosis. We would never under any circumstances, only mention the provisional diagnosis, even if the examiner asks, what is your diagnosis?
Yes, sir.
So in a case of patient having left-sided cholesteatoma, how do you mention the provisional diagnosis? Just the provisional diagnosis? I am getting ahead of myself. Before we go there, apologies for interrupting you. Let's briefly discuss what is meant by summary.
When we are talking about the summary, we will be talking about the patient particulars and the chief complaints and just the positive findings that will lead us towards the diagnosis.
Positive findings, we're talking about positive findings from history and positive findings from examination. Example of the potential positive findings in a case of left-sided ear disease having cholesteatoma.
For example, it would start like a 40-year-old male patient living in so and so region who was admitted on so and so date and was being examined by me on so and so date, belonging from the so and so religion, complaint of hearing loss or reduced hearing in the left ear for about the duration that is to be specified. And then we would go on to describe the hearing loss in particular, like the onset, the progression, any associated features that could be associated with it, or if there was any feature that would the hearing loss per se, if it affected his daily life or not, or the degree of the hearing loss that one could assess with the help of if he was able to hear whispers or not. All these things have to be mentioned. Then we would go on to any other feature that we would generally find if it was present or not. And finally, any sort of complication that could be associated with it. If it was present, then we mention, otherwise we don't. And then we move on to the examination findings, where we have found something either in the pars tensa on otoscopy examination or in the pars flaccida, and then hearing tests like tuning fork tests. All these we will talk about it.
Examination findings can reveal positive features beyond pars flaccida and pars tensa also. We might find swelling around the neck. We might find facial nerve issues. All these things are also possible. Typically, squamosal type of chronic otitis media will affect pars flaccida more than pars tensa, and also in pars tensa it would be. In which area, Dr. Thayatri?
If we are having any marginal, if you're able to find any marginal perforation or any retraction, posterior superior retraction pocket, which may have any chalky white debris, we can call it squamosal.
If you are asked to mention just the provisional diagnosis, and we know based on our examination that the patient has cholesteatoma in the left ear, how do we accurately describe just the provisional diagnosis?
On the basis of history and the clinical examination, my provisional diagnosis is left-sided squamosal chronic otitis media, active or inactive.
Already told you
Moderate.
there is cholesteatoma, so you can't go for active or inactive.
It will be active, and then with moderate hearing loss, conductive hearing loss, and no complications at present.
And how do we decide what is the degree of hearing loss?
With the help of serial tuning fork test.
What is meant by serial tuning fork test?
So in tuning fork test, we are using 256 hertz, 512 hertz, and 1024 hertz for examination of the type of hearing loss and the degree of hearing loss.
I have to stop you there. In serial tuning fork test, is it possible to understand the degree of sensory neural hearing loss?
No, only for conductive hearing loss,
So,
we are able
the
to
type
understand
of
the
hearing
degree.
loss we can understand based on other tuning fork tests. The serial tuning fork test is only for degree of conductive hearing loss.
In case of Rini's, we are starting with the 256 hertz. If it is negative only for 256 hertz and positive for the others, then the degree of conductive hearing loss would be mild. And if it is negative for 256 hertz as well as 512 hertz, it will be moderate. And if it is negative for all the three, then it will be severe.
Of course, there are ranges here. Let us discuss what are the potential complications in a case of cholesteatoma.
So again, complications can be divided as intracranial or extracranial. Extracranial can be further divided into intratemporal and extratemporal. So, intracranial would be meningitis, extradural abscess, brain abscess, subdural abscess, whereas your intratemporal complications would be mastoiditis, then um, facial nerve palsy, petrositis, and labyrinthitis. Whereas for under extratemporal, you could mention the abscesses, the various abscesses that are associated with cholesteatoma.
Authors believe that mastoiditis is the cause of these abscesses, so abscesses technically can be regarded as intratemporal complications. Let's briefly go back to the diagnosis. When you are mentioning the diagnosis, you should start, as you said, on the basis of history and clinical examination, which is a very good way of starting. My provisional diagnosis is, in this case, left chronic otitis media, squamosal type, active stage, with whatever the degree of hearing loss is. And then the type of hearing loss, which is usually conductive hearing loss in chronic otitis media, and then mention if any complications are present or not, whether they are intratemporal or intracranial. Now, can you answer a question, Dr. Saritri, for the benefit of our viewers? What are the types of hearing loss possible in a patient with cholesteatoma?
It could either be conductive or sensory neural or mixed.
So you're
I
saying
mean, it is better to say instead of sensory neural, mixed would be a better thing that could be said.
conductive hearing loss and mixed hearing loss. These are the two possibilities.
Yes.
Right. So this is something which many parents miss. They only say conductive hearing loss, and then the moment they understand that, oh, but the disease can reach the inner ear also, then they say conductive hearing loss or sensory neural hearing loss. I don't understand how cholesteatoma can only cause sensory neural hearing loss, although maybe it is possible, who knows. But better answer is conductive hearing loss and mixed hearing loss, in my opinion. Let's talk about one of the favorite questions the examiners ask whenever they are fully satisfied with the provisional diagnosis, which I must say they very rarely are. They always find some mistake or the other in the provisional diagnosis. But if they are fully satisfied, then the most favorite question the examiners have usually is, what are the points from the case that support your diagnosis? How do you answer that question?
We will begin from the very beginning with the chief complaints and the details regarding it. For example, if considering it to be chronic otitis media, if there is any discharge that the patient complains of, then the characteristics in favor of either mucosal or squamosal. Since we usually encounter squamosal cases, so I will be talking about the features of squamosal, like whether the amount of the discharge, whether it is scanty or not.
Just tell me the nature of the discharge in Squamosal.
So it will be scanty, then purulent, and then foul smelling. The color will be yellowish to yellowish greenish, and it may be associated with blood stains, and it will be there will be continuous discharge all throughout, and it will not have any aggravating or relieving features.
And from your experience, do patients with chronic otitis media squamosal type usually complain of discharge?
No, since the discharge is scanty, they are usually not complaining of discharge. Very few patients come and say while cleaning the ear they have found something or something of that sort they'll be saying. But it is not the usual complaint. Usually they come to us with complaints of hearing problems.
So it's very little discharge, that is scanty discharge, but it is almost always there. It doesn't go away completely. Is that correct?
Yes, sir.
Another favorite question of the examiner, whenever you have described the discharge, we will get to the other points in favor of chronic otitis media squamosal type just after this. But let's address this question right away. One of the favorite questions that the examiners ask whenever you hear about discharge and you say there is foul smell, then the question becomes, why is there foul smell in a discharge in a patient with chronic otitis media squamosal type? How do you answer that question, Dr. Thalitri?
It is due to the anaerobic organisms that are causing the infection, because of which there is a foul smell in the discharge.
Do you encounter foul smell in the discharge of chronic otitis media mucosal type?
I don't think it is a usual finding.
Foul smell is seen in chronic otitis media squamosal type and rarely seen in chronic otitis media mucosal type. One of the MBBS students had asked me this question, Sir, if foul smell is caused by anaerobic organism growth in chronic otitis media squamosal type, then if the same organisms grow in chronic otitis media mucosal type, wouldn't there be foul smell in that discharge also?
Possibility is there, but it is usually not the case.
One of the commonly misunderstood concepts is that chronic otitis media is primarily an infective etiology. Nobody knows for certain what the etiology exactly is. The commonly accepted etiology is related to negative pressure in the middle ear or some sort of ventilation problem. It can be infective, of course, but perhaps the argument is that bone erosion creates a favorable environment for the growth of anaerobic organisms, which leads to the production of purulent discharge. Whereas in the case of mucosal type, the same organisms are not growing, if they are at all growing, and the discharge is mostly due to hyperstimulation of the goblet cells in the mucus lining, and that is due to continuous irritation of the goblet cells, which is due to inflammation, um, which may be due to infective causes. But the discharge is coming from the goblet cells, so that is usually not associated with foul smell, is the way I would answer it. The lining of the upper airway is the same, the ciliary columnar epithelium, right from the nasopharynx. So the infection may have started in the nose and may have spread to the ear. We really don't know that. And one of the most commonly encountered situations that we have seen is that in aeroplanes, we have seen people, not patients, people, plugging cotton pledgets in their ear when I suppose the best way would have been to plug the cotton pledgets in the nose, because the so-called I caught a cold is not through the ear, it's typically through the nose and then it goes to the ear. So maybe next time plug the cotton pledgets in the nose without worrying about dying because you can breathe through your mouth. I don't know, just a suggestion. Let's talk about more serious topics, Dr. 33. So the nature of the discharge is one point in favor of chronic otitis media squamosal type, scanty discharge, foul smelling, blood stained, continuous, no aggravating, no relieving factors. What are the other points in history that can suggest a disease to be squamosal and not mucosal?
The association of any complications that might be associated
Specific examples. Instead of mentioning the name of the disease, the symptoms.
could be vertigo associated with the discharge, or tinnitus, or there could be facial nerve palsy, or other complications suggesting that there is involvement of the other areas, like there could be any abscess that could be found around the ear, um, then loss of consciousness, all these which are pain around the ear, uh, and the rest of the complications, with any intracranial complications like meningitis per se, would a patient would present with features like neck rigidity, vomiting, fever, the, photophobia, and then others like brain abscess, which also have their own kinds of symptoms.
Kind of fever would you expect in malaria, Dr. Dharitri?
It will be something that will not touch the baseline.
But it does fluctuate. It goes up and down.
Yes,
And
yes.
does it resemble any kind of complication of cholesteatoma?
Yes, it is another favorite question, which is lateral sinus thrombophlebitis, where we see hectic picket fence type of fever. That is, it resembles the picket fence, and it is like rising and reaching a peak and coming down, but not touching the baseline.
Fever produced by cholesteatoma, one of its complications that Dr. Thretri mentioned, does look like clinically, in clinical scenario, it looks like the fever produced by malaria. Now, there is a possibility, not to be discounted, that a patient with cholesteatoma may have mosquito bite and got malaria. So as a doctor, while you're treating cholesteatoma and you're thinking it is lateral sinus thrombophlebitis, the patient may be actually suffering from malaria, which requires urgent treatment because we know how serious malaria is. So how do we rule out that the patient does not have malaria?
We run blood tests for malaria as well. Uh, so the malarial parasite and the dual antigen that has to be asked for in
Yes,
the
so it's
blood.
very important to not develop tunnel vision and not only think about ear and brain, it can be something else also. That's very well said, Dr. 33. So I believe you've highlighted all the points from history. What sort of hearing loss do patients typically have in a squamosal disease?
Usually they're complaining of conductive hearing loss.
What are the symptoms patient has?
Yes, the onset is insidious, and it is either it is continuous in nature without any. It could be progressing as well, but if it is a particular unilateral side, then the hearing is usually not affected so much that it affects the day-to-day activities, or unless it's severe. Usually, the presence of cholesteatoma and there is a term called cholesteatoma hearer. So maybe in some situations the hearing loss might not get affected to a severe level.
Could you
But
elaborate what is meant by cholesteatoma hearer?
yes, the cholesteatoma itself bridges uh, forms like a bridge that is helping in the sound to pass through the ear. And in such cases, post surgery and removal of the cholesteatoma, the hearing does not improve, instead worsens.
Just for the benefit of the viewers, I will simplify the hearing process. When somebody is speaking, the sound waves are collected like a funnel by the pinna. They are channeled through the ear canal, the external auditory canal. It reaches the tympanic membrane, which starts vibrating. Then it gets amplified with the help of the small bones in the middle ear, known as the ossicles. And then these vibrations are transmitted to the cochlea through the oval window, where transduction happens. Mechanical energy is changing into electrical energy. And then beyond the cochlea, through the auditory pathway, the sound reaches the brain. Now, what we are talking about here is the problem is lying somewhere in the middle ear. That is why chronic otitis media. So, problem might be in the attic, that is the upper part of the middle ear, also known as epitympanum. It may be in the mesotympanum, middle part, or hypotympanum, lower part. Usually, the disease can have bone eroding properties. It always has bone eroding properties, and it can erode the ossicles. Now, because of the gap created between the ossicles, there should be difficulty hearing, but it is not there to a great extent because the gap created by the cholesteatoma is also filled by the cholesteatoma. And now when you remove the cholesteatoma, then the gap again is there. You could go for ossiculoplasty in the same sitting, but many surgeons prefer to eradicate the disease in the first surgery and then go for hearing reconstruction in the next stage of surgery. If that is the case, if it's not reconstructed, the hearing mechanism is not reconstructed in the same stage, almost always patient says that the hearing has worsened, which should be part of the informed consent obtaining process, explaining clearly to the patient that the hearing can worsen even after the surgery. So that is good. I believe we have discussed very many important points. What are the examination findings that we can find in cholesteatoma?
There could be a posterior superior retraction pocket with chalky white debris, or there could be an attic perforation, or there could be again your attic cholesteatoma that can be present.
A piece of brownish debris just present in the attic. How should you approach it?
Should be cleaned and examination of the attic should be done.
Under microscope?
Under microscope, but during the exam, I don't think that is an option.
Right. The logic is that if wax is present, it will be present all over the ESC, not just in the attic. If there is debris in the attic, it may be due to cholesteatoma, an attic cholesteatoma. So it's very important to look at the attic very carefully. And as Dr. Thuritri pointed out, usually microscopes are not available during long case. So the final question with which we will end this discussion, and if you found this useful, do let me know in the comment section. We can discuss this in greater detail when we have more time, which we will have hopefully soon. So the final question I have, with which I will let Dr. Dhuritri off the hook, is a very good definition was given by Abramson et al. It is excellent but very difficult to remember. So Dr. Dhuritri, could you please tell me the definition by Abramson et al. Of cholesteatoma?
Yes. It is, according to Abramson et al., cholesteatoma is defined as a three-dimensional epidermal and connective tissue sac conforming to the architecture of the middle ear, attic, and mastoid, with a capacity for progressive and independent growth at the expense of the underlying bone and tendency to recur after removal.
That's brilliant. Thank you, Dr. Dhuritri, for your time. Did you find cholesteatoma a very difficult topic to remember for long case?
Yes, cholesteatoma, each and every question and every topic in it has to be known very well. So I think it is a difficult.
So what else do you have for people who might be very nervous about these long cases?
Regular practice with teachers and peers will help.
Do you think watching this video will help?
Yes, sir.
Okay, thank you for that much hesitated endorsement of my efforts. Bye-bye, Dr. Dharitri. Hope to see you soon.
Yes, sir.
I hope you liked this session with Dr. Dharitri Mukherjee about chronic otitis media squamosal type. If you want more such interactive sessions, then do let me know in the comment section. I would request you to not forget to be awesome.